Thank you for the kind introduction and for the opportunity to be able to come share with you today. Like Rena said, I'm from Nebraska. I'm born and raised in Nebraska, and I spent 2 years in Philadelphia, so I have lived on the East Coast, and I actually have been to New York City before. After my time spent in Philadelphia, I actually worked in Detroit for 5 years as well at Henry Ford Hospital before going back to Nebraska almost exactly 3 years ago. In preparing for coming to the city today to give this presentation, did a little bit of background and really looked at a map to try to figure out where it is as we were staying and where the college was and kind of what I could do to necessarily get around, and found this map, which is actually the first thing that came up when you say map of New York City. What I was most excited about, however, is that Nebraska is actually identified. I know you can't see it, but this actually says Nebraska. So someone actually did understand this, and what was interesting is it's written by some guy named Steinberg. No, I know Dan from residency stuff. So when I looked at this, I was like, hey, there's actually Nebraska there. One of the things that in the spirit of education, one of the things that I really want to try to do is actually let people know where Nebraska really is. So this is Nebraska here, right smack dab in the middle of the country. I actually think the true geographic center of the United States is in northern Kansas, so just a little bit below us. And the geographic center of North America is actually in South Dakota. I think those are true, but so we're smack dab in the middle of the country. And one thing I also want to note is that this is all latitude, right? And that latitude isn't somewhere in the Arctic Circle. This isn't the topography of Nebraska. It's not the frozen tundra. It's actually very similar. The weather's very similar. And I had to really try to convince people in Detroit that Nebraska wasn't in the frozen tundra. And I actually had to remind them that Detroit itself is actually north of Canada. It's actually physically north of Windsor, Ontario. And I have to remind them that Nebraska is really no different. Now, we have our cold days and we have our snow days. We also have very beautiful days as well. A couple other things about Nebraska. Here's just some pictures about it. Your skyline wins. No, hands down, your skyline wins. I think we probably have more of this than you do. At least ours are made out of real bricks and not concrete. And not quite Yankee Stadium either. This is where the College World Series is located as well. I'm a big baseball fan, so not a Yankees fan by any stretch of the imagination. Sorry. I'm a Royals fan, and I was 12 years old when the Royals won the World Series in 1985, so I don't like the Yankees at all. One of the coolest experiences, though, was actually sitting about the second row at Yankee Stadium with my kid when he was an infant. So, one thing, though, that we have that you don't have is this guy. Is Warren Buffett. You might have Wall Street, you might have a stock exchange, we have Warren Buffett. And everybody seems to know who Warren Buffett is. So this is the University of Nebraska Medical Center and our hospital, the College of Medicine as well. So just a couple slides. If you've never been to Nebraska, it's a wonderful place to be, wonderful place to live. So I encourage you to go visit sometime. In terms of disclosures, I have nothing disclosed today. The 3 objectives that I have for our talk. I'm going to sneak around here, and I have my phone here. I'm just going to press it from time to time to check time. Promise you I'm not checking emails and stuff. The goals for today, one is at the end of today, I hope you're able to evaluate the shortcomings of our current system of medical education, to identify challenges to accomplishing the goals of competency-based medical education, and then recognize CBME as an opportunity to achieve meaningful medical education reform. So a quick outline. We'll spend a brief amount of time doing an introduction to competency-based medical education and really trying to think about the imperative for medical education redesign, right? We're experiencing it. We're a bit of fish in water. There's a whole bunch of medical education redesign that's happening right now, but oftentimes in our day-to-day work, we don't recognize that it's changing. And then I'll also address 5 challenges to achieving the promise of competency-based medical education. In conjunction with the title of the talk. We'll spend a lot of time really on the first 2 challenges and then briefly mention 3 other challenges. One thing I want to apologize for is I woke up this morning and I think I'm starting to get a cold, so from time to time, if I'm talking fast, it's because I'm trying to actually get my breath. So I ask you to think about, just spend a moment, what does competency-based medical education mean to you? And hopefully this kid at the bottom at the Midvale School for the Gifted is not your idea of what competence is. Okay. We'll come back to this, and I hope it's hope you can able to think about what it is that it means to you. So the international CBME collaborators, a lot of the work and the talk today is based upon my experience with this international group. So I've been involved with this international group now for a couple years. This was actually a definition that they developed during their first meeting back in 2010. Actually, it was in 2009 and published in 2010. And a lot of the work, a lot of the ideas that I'm going to mention today are based upon my experience with that back in 2013. So they have defined CBME as an outcomes-based approach to the design, implementation, and evaluation of a medical education program using an organizing framework of competencies. Pretty straightforward. It's really an approach that's intended to be learner-centered, meaning that it's individualized. It's not necessarily a framework that is a one-size-fits-all. It's formative, and what it does is that it uses mentors and coaches as opposed to judges and juries. It's competency-based, obviously makes sense, meaning that there are predefined knowledge, skills, and attitudes. It's focused on learner abilities and not their capabilities. It really doesn't matter if the learner is capable of doing something. What matters is can they do something or not. And doing that implies is that we have to use things that are called observable behaviors, and that it's outcomes-driven, meaning that it's measurable and it's improvable. You can actually do something, measure it, and measure its improvement. Carol Caraccio, I think it's been over a decade now, wrote a wonderful paper that I still use. I think it really helps to explain and understand competency-based medical education. And this is a part of a table that I've pulled out and added to this talk. What she does is she compares a traditional educational program historically based upon structures and process, which is what a lot of our medical education programs have been up until now, with what would be a competency-based system. And you can see that the curriculum now is based upon outcomes, where in the past it was based upon the content. I'm an expert at disease X, and I want to impart to you all of the knowledge about disease X. The goal of the educational encounter is actually not in the knowledge acquisition, but it's in the application. Again, it's what does the learner do, not what is the learner capable of doing. The assessment tool needs to be authentic in a competency-based system, meaning it's not by proxy. Our multiple choice exams are a proxy measurement for competence, and they aren't necessarily authentic. The setting often requires direct observation. We'll spend in our second challenge, we'll talk a little bit about direct observation. The evaluation it needs to be criterion reference, so it's based. You base it against a certain criteria, as opposed to you base an assessment against average or against someone else or against a level of training. The timing of assessment in competency-based education, the emphasis is really on formative, again, because the idea is to help you to be able to grow and less summative, where there's a right and a wrong or a yes and a no. In the program completion, in a competency-based system, in a true competency-based system, actually has variable time. And that's one of the biggest challenges, and we'll briefly mention that. I think it's in the third or the fourth challenge that I'll mention towards the end of the talk. So the paradigm shift of CBME, again, there's a huge focus on it. It has been really over the last 5 years or so, but it's not really a new topic. Dating back to 1970, there were actually calls for competency-based training. And you can see every 10 years or so, a new iteration or new thought would come out about this. The ACGME, in its outcomes project, actually defined it in 2000 when they introduced the 6 general competencies. The milestones really began in 2010, and you can see that it's happened quite a bit over time, but things have accelerated. So that paradigm shift has really changed quite a bit. And what has driven that? I would say it's several different things. One, in 2001, the publication of the Crossing the Quality Chasm report actually put an emphasis on, it calls out medical schools and calls out our educational structure as really being inadequate for our health delivery system. It was followed up later on when it specifically calls out academic health centers. And really one of the most sentinel things was in 2010, the publication of the MedPAC report, which actually threatened GME funding. When the policymakers actually said, you know what, you're not doing what we need you to do, we're going to think about pulling that funding away. We still live under that threat today. But it's not just those reports. There's actually other literature coming out that we actually haven't necessarily been doing a good job, I would argue. Jay Crossan published an article in Health Affairs in 2011 where talked to bosses, for lack of a better word, in the Kaiser Permanente system and asked about the competencies or the skills that are lacking in graduates that enter into their system. And this was in multiple different specialties, and this is a long list, I won't go through them, but different gaps that individual faculty members had when they had become quote unquote unsupervised faculty, meaning when they entered the real job world. And there were lots of skills that those graduates were necessarily missing. I don't have there's another article that I've read that I don't have a slide for, where through the Surgery Program Directors Association, the fellowship directors, actually general surgery residents entering into fellowship, ran into that same thing. They actually weren't able to do general basic surgery after finishing a surgery residency. They went into fellowship, and that's where they actually got some of the skills to go forward and be able to do surgery unsupervised. So there's, and this is just one example. My intent isn't to do a deep dive into that literature, but just to highlight that maybe we haven't been doing what we should be doing. When you put all of it together, I think there's an imperative for education redesign. It's safe to say that medical education historically has not sufficiently responded to the shifting patient expectations and demographics. The world around us has changed, but medical education historically has held pretty true and pretty steady to what it had historically done, even dating back 200 years to the Flexner Report. We haven't responded to the changing health delivery systems. Healthcare has changed around us. How health is delivered has changed around us, but education necessarily didn't keep up with that. We haven't responded to the need for quality improvement. We haven't responded to the need to the use of new technologies. So how many of you in this room, particularly those that say have graduated in the last 5 or 10 years, actually were taught how to interface with an electronic medical record? Short of that 30-minute module that you have to do once a year to maintain compliance with whatever, or like with us, when Epic was rolled out and said, here, go to this class and hope you pick up something, right? It certainly wasn't incorporated into my training over the course of time. In summary, medical education is not meeting the nation's healthcare needs. This book, Educating Physicians by Molly Cook and her colleagues at UCSF, I think really points out in this quote what it is that we have to do. So medical education is at a crossroads. Those who teach medical students and residents must choose whether to continue in the direction established over 100 years ago or take a fundamentally different course, guided by contemporary innovation and new understandings about how people learn. Which brings us back to this slide again. Again, the approach to CBME. The CBME, I believe, is our transition and our response to that statement, and our opportunity to actually think about how it is as we do education into the future. I'm going to shift gears a little bit, introduce you to my nephew. This is Brady. His picture's actually getting a little old. The first time I used it was about 3.5 years ago. Brady's now actually a freshman at the University of Nebraska as a Regent Scholarship. You would never know based upon this picture, but he's actually an exceedingly bright kid. And this picture was taken in August of 2010, so it was taken exactly 2 weeks before his 16th birthday. What happens to kids in this country when they turn 16? They get to drive a car. So I ask you, how does Brady get to drive a car? Think about that. I'm going to introduce a couple definitions. Don't get freaked out by the definitions. Again, this is just helping us think about and creating that background. So what is a competency? A competency is an observable ability of a health professional integrating multiple components such as knowledge, skills, values, and attitudes. So an observable ability. What is competent? Competent is when that person possesses the required abilities in all domains in a certain context at a defined stage of medical education or practice. So possesses the required abilities. And what is competence? Competence entails more than the possession of knowledge, skills, and attitudes. It requires that you apply those abilities in the clinical environment to achieve optimal results. So being from Nebraska, fairly simple-minded, I understand that. Taking those definitions were kind of hard to understand. I put them together into Competenglish, something that I think makes more sense. What is a competency is the thing they need to do. What is competent is when they can do all of those things. And what is competent is does all of the things consistently adapting to contextual and situational needs. I would argue that we're aiming not just for competent, we need to aim for competence, okay? And we'll talk more about that. So how does Brady get to drive a car? So going back to Brady and taking those words and thinking about it in terms of driving a car. So the competency is when he can accelerate smoothly. He can brake smoothly. You have to be able to do that to drive a car, right? But doing that alone does not mean he can drive a car. But you have to be able to do that to drive a car. He can approach an intersection and can turn left. A little bit more complex, a little bit more difficult, but unless you drive for NASCAR, that's not good enough, right? You have to actually be able to turn right too. Competent. So that's when he can pass the driver's exam. He can pass I passed the driver's exam to get the license. He can actually do driver's ed classes, but that in and of itself doesn't mean that he's okay to drive the car. It just means that he's passed the exam. Competence is when he can drive safely on the interstate. Multiple different things in a different context, and he can put it all together and drive safely on the interstate. He can drive during bad weather. He avoids accidents. He doesn't get traffic tickets, et cetera, et cetera. But in reality, how does Brady get to drive a car? It's when his dad gives him the keys to the car and walks away. That's how it really happens, right? So I ask you, when do your residents and when do your fellows get the keys to the car? How have we historically done this? Is it because they've always had lots of good evaluations? Everybody likes them. They're great. Yep. So I'm going to give them the keys to the car. They've had an absence of bad evaluations. Well, nobody said anything bad about them, so they must be good, right? Because they survived 3 years of training. Unfortunately, I think this is actually very accurate for internal medicine. They made it through 3 years. They didn't get into too much trouble. They must be pretty good, right? So we're going to let them enter into unsupervised practice. A lot of time it's because the program director actually followed the rules. Program director set up a program, and this is our old structure and process-based. Program director set up a program. The residents went through that program, so obviously the residents are good. Think about that. That's kind of nonsensical how we've historically done that. Competency-based education is actually a new paradigm. We must know that the trainee has demonstrated competence, going back to that word competence, and is ready to progress to the next stage of their career. It requires a clear definition of the expected competencies, it requires a clear definition of what they're expected to do, and it requires assessment to determine whether they've done those things consistently and within the contextual needs of the clinical environment. So going back to that definition of competence. I think this is probably the most important slide that I can talk about today, really comparing what a traditional model of education has compared to a competency-based model. So up here on the top, in the traditional model, we historically used to start with a curriculum. Remember I mentioned disease X, and I'm the world's expert at disease X. I'm going to inculcate you with all of the knowledge you need to know about disease X, right? I'm going to assess, I'm going to write objectives about it because I want you to learn about disease X, and I'm going to assess whether or not you met my objectives, okay? In a competency-based model, it's flipped on end. I'm going to start here in the middle, where we actually start with our outcomes. We start with the competencies. What's expected? What do I expect you to be able to do? What is the outcome that's expected? And importantly, I actually make an assessment on whether or not you met that outcome, as opposed to assess whether or not you met my objective, right? I have to define what that outcome is. I still have to teach you, right? I still have to find a way and actually teach you, but the curriculum reflects the outcome expected and not the other way around. Historically, we had the curriculum come first. Here's what I want you to learn, and my outcome is going to be whether or not you mastered what I think you should learn, as opposed to in a competency-based system where the focus is here in the middle on the outcomes. Now, curriculum and assessment have to be tied together still. My criticism of this slide is that there should be a dotted line that connects the curriculum and assessment together, of course. But again, our focus is on outcomes. And then more than that, those outcomes aren't something that I think is important. Those outcomes should reflect the needs of our health system. They should reflect what our health system needs us, say in medical education, what we need of physicians to be able to do. So think of your training program, okay? What outcomes do you expect of your trainees? So everybody here has worked, no matter what level of training or what specialty, everybody here has worked with a trainee at some point in the recent past. Think of the most recent resident or medical student that you worked with, and just think of one outcome that you expect of that trainee, okay? And then what are the current outcomes that are demonstrated by your trainees? Okay, this might be a little What are the current outcomes demonstrated by your trainees? And the way you answer that, what assessments of the trainees do you currently perform? Think about that as we go through this next slide. So I know you can't read this, and that's okay. The purpose isn't to necessarily read it. What this is this is 6 months of summary data from a real live internal medicine residency program in this country, okay? 6 months of residency data. They have a 9-point scale, having unsatisfactory, satisfactory, and superior, okay? The resident here is Susie Smith, and Susie is a third-year resident, okay? This here is the average for Susie, and on the left-hand side is broken up into 6 CBME general competencies. So that's the average for Susie, and this is the average for Susie's peers, right? So let's look here at medical knowledge. Susie has a 7.74 out of 9, and her peers have a 7.29 out of 9 on medical knowledge. So Susie is obviously smarter, right? That's the outcome. Susie's obviously smarter. Look here, practice-based learning and improvement. Susie's a 6.93 out of 9, and her peers are a 7.19 out of 9. So she's below average. She's a below average practice-based learning and improver, whatever that means. She's below average at it, whatever that means. Let's look here at professionalism. She's a 7.21, and her peers are a 7.85 out of 9 for professionalism. So she's obviously not as professional. Now, anyone care to raise their hand, or anybody have the hair stand up on the back of their head when they see this? Right? Why? Because as sage or experienced educators will look at this and ask the next question will be, what's wrong with Susie? Right? Because when you flip the page over and you see all of the written comments about how they don't want to work with her, and you talk to the program coordinators and how all of the residents don't want to work with Susie, and you get the emails from the nurses because Susie actually doesn't play as a team, she's rude. You talk to other faculty, you have the 4 or 5 hallway conversations when the faculty comes up and says, what's up with Susie? Something's wrong with her, right? She's mean, the residents like her, right? We've all experienced that before. Program directors, you get that all the time. But yet, what does the data show? She's a 7.21 out of 9, which is what? Superior. Even though she's way below, quote, average, right? She's still superior. You can see it's not really, not very robust, not really helpful. So what are the demonstrated outcomes in this particular case? Superior and above average. The outcomes is that they perform better than their peers, that they're appropriate for the level of training. So our outcomes aren't necessarily demonstrate. I would suspect that when I had you think about that most recent trainee that you had, these aren't what came to your mind, right? When you think of the resident you worked with most recently, you didn't think about, well, I hope they're above average, right? That's not what you thought about. That's not the outcome that you were aiming for. Again, do these things match your expected outcome? In our new world, right, so the milestones are that first attempt, that first iteration to actually define what those outcomes are and define them, like I mentioned before, in an observable behavior, right? These aren't above average. These aren't below average. These are actually observed behaviors that are written in a developmental fashion. Now, every specialty has a bit different idea behind it, but again, the milestones kind of defined what those outcomes should be. But we still had a struggle, right? We had a struggle, and part and parcel. So after the milestones, right as the milestones were being introduced, we recognized we still had a struggle. We think back to 10 years ago when the ACGME general competencies were introduced, and we recognized we still had a struggle making that transition to competency-based education. Why did we do that? I think I would submit to you that it was because of the unclear and complex ACGME general competencies. What exactly is practice-based learning and improvement? I mean, I live and breathe this stuff, and trying to actually define that for someone who doesn't live and breathe it is still a hard thing to do. And more so, the difficulty in assessing and evaluating resident competence in those general competencies. So what exactly equates to competence in practice-based learning and improvement? Still really a hard thing to do, which that brings us to the first challenge. And our first challenge is, I talked about, we must ensure that the outcomes of the assessment actually demonstrate competence in the activities that define the profession. That's our big challenge. And in that, I think there's lots of literature that's really coming out, and something that I've been happy to contribute to is in entrustable professional activities. So let's talk a bit about EPAs. So what are EPAs? EPAs identify the critical activities that constitute a specialty. They're the activities by which we would all agree should only be carried out by a trained specialist. Olitz and Kata actually define what these might be. So in these EPA, so an EPA is part of an essential work for a qualified professional. My mother's a retired high school teacher, so these aren't things that my mom can do. They require specific knowledge, skills, and attitudes, right? So they actually have discrete components, knowledge, skills, and attitudes that go into this activity. They're acquired through training, right? I wasn't born with them. They're things that I actually had to acquire through training. They have a recognized output, so you know it when you see it, you can measure it, right? I can observe a trainee, I can observe a resident go through it and see them actually do this. It's observable and measurable, so therefore I can arrive at a conclusion. I'm not using proxy, I'm actually watching them do it. And it reflects the competencies, the things that they need to do, right? Driving on the interstate would be an EPA, if you will, and it requires multiple different things all going on at the same time in a certain context. Together, EPA should constitute the core of the profession. There's also another component to it, so that's the activities part. What about the entrustable or the entrustment part? So Ola would argue that patients and instructors' entrustment of responsibility to a trainee is an essential concept in this approach. I would argue that we do this all of the time. And Tara Kennedy actually demonstrated that. This is something that we do, but we do it quite by accident all the time. We know that attending physicians assess a multidimensional construct of trustworthiness when deciding upon a level of supervision. Right? You as a faculty member do this all of the time. You know the resident that you've worked with. You work with 2 second-year residents, no matter what specialty you're in. And Susie over here, I'm going to watch like a hawk. And Bobby over here, Bobby's pretty good. I'm going to let Bobby give him a much longer string. Right? We do this all the time. Program directors do this all the time because it's who, for internal medicine, let's say, who actually is your inpatient ward supervisor in July and who's not your inpatient ward supervisor in July. You know who those are, right? You're probably making your schedule right now for the upcoming year. More often than not, you're making decisions based upon the time of the year, right? You don't have evidence that goes into that, but you make decisions based upon entrustment all of the time. In Tara's article, she actually defines that entrustment implies a level of competence. Here we are back to this word again, competence. So I would submit to you that this is what we're aiming for. So what does an EPA do, right? Can you still see competence here? Okay, this is a concept that a colleague of mine when used to be at the American Board of Internal Medicine, Bill Yopst, he's now at the Commonwealth Medical College as their vice dean, but a concept that we came up that we refer to as windows to competence as well. So what an EPA does is it helps us to think like this. So I would argue an entrustable professional activity. No matter what specialty you're in, you have to be able to lead and work within an interprofessional team. I don't care what specialty you're in, you have to be able to do that. Okay, so we're looking for competence in this EPA. So for me and my program, me and my residents, right, I know that they need to be able to accept feedback if they're going to lead and to work within an interprofessional team. They need to be able to manage diverse opinions with the goal of optimizing patient care. They need to maintain a climate of mutual respect and shared values. They need to engage in collaborative communication, and they need to identify and understand roles of team members. But notice that each one of these individually doesn't equate to competence. It's only when you put them together do you actually see competence. More so, it's actually very synthetic as well. When I look at this, I'm not just looking here, accepting feedback, right? This is practice-based learning and improvement. Maintain a climate of mutual respect and shared values. Professionalism. Identify and understand roles of team members. Systems-based practice. Manage diverse opinions with the goal of optimizing patient care. This is patient care. Collaborative communication. Interpersonal communication skills. It actually incorporates multiple ACGME competencies, and it does so in the context of this. If we take this away and if we take this away and we don't define the context in which I'm doing an assessment, this just turns into a checklist, right? A checklist of things that they can do. And again, our trainee can do any one of these windows individually, but they have to be able to do them together in the context of what it is that I'm looking for. So an EPA is really an assessment strategy. EPAs provide meaningful context. They're the work-based activities of our profession. They integrate multiple competencies so that they're synthetic. I just demonstrated that. It synthesizes multiple different competency domains into a meaningful assessment. They act as a bridge to connect those ACGME competencies to real-world practice, which I think is what is most valuable. In that bridge, the faculty actually get it. It gives the faculty an opportunity to understand. You ask your faculty member on a scale of 1 to 9, how is Susie at practice-based learning and improvement? They don't know what to give you, right? Because they don't understand what it is. I didn't wake up this morning thinking about what am I going to be, what am I going to do to be a better systems-based practicer today? That's not physicians don't do systems-based practice. We work and lead in interprofessional teams, right? That incorporates and brings part of systems-based practice into it. So EPA is an assessment strategy. But it leads us to question number 2. If faculty are a key component of this, the challenge is actually the faculty expertise in assessment. You're unlikely to have successful assessment without having faculty training first. Always remember, we're not going to aim for a perfect tool. I think EPAs provide us a new way to think about how to do assessment. I think we have a greater opportunity because rather than trying to drill in the head what a 5 out of 9 is for systems-based practice, what an EPA does is it allows the faculty member to actually understand what it is that they're assessing. Hasn't historically been the case. The thing that the real goal, though, to make EPAs work is in that context of direct observation. This is a quote from George Engel, who I believe was a psychiatrist up in Rochester. It's a pretty interesting quote because it equates how medical education historically would work. If musicians learn to play instruments, as physicians learn to interview patients, the procedure would consist of presenting lectures or in demonstrating the theory of mechanisms of the music-producing ability of the instrument, and then telling the learner to play. The instructor, of course, would not be present to observe or to listen to the student's efforts, but would be satisfied with the student's subsequent verbal report of what came out of the instrument. Right? We don't learn how to play a saxophone by teaching you the theory and the mechanisms for how a saxophone works, and then send you in the other room and to practice on it and come back and tell me how you did. But yet, that's what we've historically done in medical education. We teach you how to take care of a disease, how to work with a patient. We have you read about it, and then we send you off and hope that you do it well. Direct observation is really a very difficult thing. It sounds pretty simple and pretty straightforward. This is actually very seminal work, what I would say is seminal work by Jen Kogan down at Penn. Dan and I were colleagues of hers 5 or 10 years ago. But she presented a conceptual model. And it's really difficult. I'm not going to spend a whole lot of time walking through it, other than to point out, the trainee and the patient are down here. And this is meant to represent the faculty member. And the faculty member is looking through a lens at this encounter. The faculty member isn't agnostic. The faculty member has their own emotions, their own that's informed by their background, their beliefs, their own particular history. The faculty has his or her own competence and their own traits. The faculty brings that to the table. They can't ignore those. That's who they are. They look through a lens. They make some inference. Inference is a really key component. What does this mean?
Closed body language.
Closed body language, right? That's the natural inference that we would all make if I see a trainee doing this. When we actually ask the trainee, they're either cold, they're scared to death, right, because they've never broke bad news before. We make inferences all the time. That's the lens that we look through. The frame of reference is that we all look for different things. In other words, the faculty has a really complex role in this direct observation. And then we actually ask them to synthesize that observation, provide evaluation and feedback. And all of this is really complex. And what's down here is that all of that is a potential area for faculty development. So just telling our faculty members to go watch isn't necessarily good enough. We have to teach and train them how to actually do the observation. What are some strategies to increase direct observation? A big challenge. This is a really huge challenge at our institution. One thing that doesn't mean you have to go watch for 7 hours and watch them go through the day. Try to find frequent snapshots or sampling. So take an interview and an agenda setting. First patient of the day, In an ambulatory clinic, I'm going to go watch you. We're going to go watch the first 5 minutes of this encounter. 5 minutes of this encounter, as opposed to me sitting at my desk. I'm going to go in and I'm going to watch you do that. Physical exam. Whenever you have a painful joint, instead of examining the painful joint and then coming and get me and then I'm going to go back and examine the painful joint again, and the patient gets more upset because says, why do you keep, my knee hurts. Why do you keep causing my knee to hurt? Come do it with me. You go do it together. Counseling. Whenever you're starting a new medicine, come grab me because I want to watch you once or twice as you start a new med. Make the observation learner-centered. So who was your most challenging patient? So as a faculty member, go to your trainee and say, who's your most challenging patient in your clinic today? On the inpatient wards, who's the most challenging patient? Where do you not know where to go? Let's go see that person together. What are you working on? What can I help you with today? Because the trainees are actually thinking about this all the time. What do you want feedback about? So these are different strategies to be able to increase direct observation. What's our third challenge? The practical implication of CBME in a time-based system. That's pretty scary, right? We have a time-based system and our funding mechanism is structured and based upon that time. It's a real barrier. So what do we do about remediation or the advanced learner? Are we really going to send residents, internal medicine residents out after 2.5 years? Are we prepared to do that knowing that I lose 6 months of that salary too, right? Or 6 months of that Medicare funding. And what's the role of the resident as the service provider? Right? Someone's got to take care of those patients, and if I graduate them earlier, who's going to admit and discharge the patient from the hospital? These are real problems, okay? Some potential solutions: individualized learning plans, time for enrichment. So pediatrics, the American Board of Pediatrics and their RRC are actually mandating individualized learning plans. So what do we do with that internal medicine resident in the last 6 months of their training? Can we actually enrich that to prepare them for whatever they're going to do next? Whether it be a cardiology fellowship, whether it be a hospitalist, whether it be an ambulatory setting in ambulatory office in a rural setting, what can we do to move them and prepare them for their next career? Some potential solution is the entrustment-based supervision and autonomy. This is something that I'm very interested in. At what point, why is it June 30th that I still have to sign their inpatient notes? But on July 1st, they can sign it themselves and bill for it. We need to find a way to get around that, right? To where once you've developed entrustment, that you can actually advance them forward. There's a study that we're going to start to develop, that we have developed and going to start to implement in Nebraska with using teleeducation. So me acting as a preceptor when actually the resident is 200 miles that way. So I'm actually still supervising their care, but I'm doing it from 200 miles away. Think about that. It's pretty interesting. There are pilots about this. The University of Toronto, their orthopedic surgery program, has actually made the transition. They piloted this maybe 5 or 7 years ago. It was such a success that it's fully competency-based now. If you're interested, next month, they actually have a workshop. They do a yearly workshop now, a day-long workshop that actually describes how it is as they move fully to a competency-based system. So their orthopedics residents graduate when they're ready, not graduate when the program when they don't graduate on June 30th. They graduate when they're ready. Challenge number 4, the cost of CBME, both in time and in money. Faculty development direct observation take time. It's a whole lot easier to sit at my desk at 8:30 at night or sit at home at the kitchen counter at 8:30 at night and fill out an evaluation. It's really hard to find the time to actually go watch them. There's lost revenue from clinical care. Me doing that means that I can't see patients over here, and we have a lot of pressure for us to see more patients over here. So how can we get around that? Incentivize and reward time spent in education. I think this is an advocacy component that we as educators need to start to take a better, have a better grasp of. We need to link CBME to cost savings, right? If we actually spend time adequately preparing our trainees now around, let's say, quality improvement, what's going to happen in 2 years and in 3 years and in 5 years and in 10 years when there are faculty members? They're actually going to do quality improvement. They're going to do cost savings. They're going to try to do, they'll be able to, we prepare them now so that when they join us in the future. This is the big win that I've had in working with our health delivery system, is trying to actually have them recognize this is really valuable. Let's train them first on how to do the things that we need them and want them to be able to do, and not lament 10 years from now and have to remediate them about all of the things that we didn't teach them before. Let's teach them up front. We need to allow education to be more efficient, right? Why can't trainees bill for service? Because the rules say they can't bill for service. Why can't they? I spend so much dang time, hours. I'm on service next week. I'll spend 2 to 3 hours every day reviewing their documentation, making sure that all the boxes are checked appropriately, trying to find the right special words for billing and documentation when it's redundant. Why am I doing that when I can have some trainees do that? Challenge number 5. There's an existing artificial dichotomy between medical education and medical practice. So training in tertiary care center versus the community center. Now that this is, I don't know your guys' context very well, but we have all of our training, or not all of our training, the vast majority of our training still occurs at the Ivory Tower located at 42nd and Emily Streets in Omaha, Nebraska. But where do the vast majority of our trainees go? Way out there, 200 miles that way. And that's where they practice. We train them to be, we graduate phenomenal third-year residents. I would imagine you do too. What's wrong with that? Should we really be hoping to graduate third-year residents that work in my system? No. Our goal is to graduate physicians that can practice in their future environment. We train them very well to be a resident in our system. We don't necessarily train them very well to practice like they need to out there. Think back to that Jay Crossan article, right? One at Kaiser Permanente. We train them exceedingly well to work exceedingly efficiently in my system. That's not what I need them to do. I need them to work out there. To do so, that means they actually have to work out there, and they need to train out there too. The second bullet there, training competent physicians requires training in competent systems. This is a statement that's based upon a series of articles, which I think are actually very seminal, by David Ash. He's published a lot of them in JAMA and New England Journal, that actually demonstrates that if we're going to train competent physicians, they actually need to train in competent systems. What this means is that we actually have to have an integration between our clinical delivery system and the educational system. They have historically lived in 2 separate silos where they had to crosswalk, and I think they actually have to form into a partnership together. One of the potential solutions, I think it's time for that we actually embrace the social accountability. Our job isn't, at least I can speak for us in Nebraska, my job is to train physicians for the state of Nebraska, not train highly skilled academics, so that I can find 1 or 2 of them to stay in my system to keep feeding me forward, right? We need to train physicians for the state of Nebraska. That's what my I'm being held accountable to be able to do that. Think about extended learning arrangements with trainees. How cool would it be to actually have the resident leave, but still have an extended agreement? You need continuing education, come back to the mothership. We're going to come back here. We're going to train you in the highly skilled procedure, the highly skilled technique or competency that it's going to be difficult for you to learn out there. So I still have responsibility for your outcomes, even though you're practicing 200 miles that way. I still have responsibility for your outcomes, but you need to be able to come back. And we develop some sort of extended learning relationship so that you don't necessarily cut the cord, right? The way we can accomplish that, go practice out there for 200 miles, learn the system, practice the system, come back and I'll help you. You're going to teach me as much as I'm going to train you as well. I'll skip for time purposes, I'm going to skip that last point. Just a reminder that these challenges aren't new. Remember back in 1970, we started talking about this. This is for internal medicine. 3 really sage senior leaders commented on this, and these are some of the things that they discussed back in an article in 1997, and they're very reflective of the things we've talked about till now. Right? The need to have integration, better systems of evaluation. We need to actually have learner-centered residency programs. So last couple slides. To achieve the promise of competency-based education, to achieve where we want to be able to go, I would argue that we have to have some changes in our structure. We need to eliminate the current silos that define the continuum of medical education. We have a very defined undergraduate, graduate, continuing education. We need to eliminate those silos. Education never stops. It never ends. When you leave residency, that doesn't mean you go into continuing education. It's the same process. We need to blur those lines. We need to work with education stakeholders and policymakers to establish policies that support the principles of CBME. One of our biggest barriers to do that rural study that I'm describing is the simple fact that I can't bill for it, and neither can a doc out there bill for it, right? Because the rules say I can't bill for it. How are we going to capture revenue? We still got to capture revenue, guys. But how are we going to do that? How can we get around the rules and the regulations? Thankfully, the CBME has, in the next accreditation system, has purposefully changed and allowed programs a lot more flexibility to be able to innovate in this realm. And then integrate medical education into clinical care delivery throughout the continuum of education. The vast majority of my job is focused on that last bullet right there. I spend a lot of my days working on that. If you go, anyone here is going to CBME, I'm giving a talk on Friday morning about how it is that we're doing that back in Nebraska. It requires us that we have changes in process, focus outcomes of medical education towards meeting the needs of patients and communities, as opposed to meeting the service needs so I can get through the day to day, or my program, my department can be sustainable going forward. It's going to take collaboration between professions and collaboration between stakeholders. So one of the really interesting things is that, I guess I did mention that PCFDI is out on the last screen. Internal medicine, pediatrics, and family medicine all working together, the boards, to actually define a single outcome. Seems like that's something we should do readily, easily. Really wasn't easy. It took years for each of the boards to necessarily get and have an agreement just upon a simple pilot study. And then finally, design systems that facilitate the demonstration of outcomes, right? Our systems right now still lead us to taking an exam. I would argue we need to change our process. We also have to change our culture. Embrace transparency and accountability. Physicians we've done this, but we haven't done this with regards to our training. Okay, putting a big funny mirror right in front of us is something that is important to do. I personally believe we need to quit blaming our trainees. I heard it last week, and actually just on Monday, my own institution. Well, but these learners, these students, right, they don't care as much. BS, they care just as much as you and I ever cared, okay, if not more. We blame the trainees for the failing of our system. Allow faculty to be a mentor or a coach. EPAs allow the faculty to be a mentor coach as opposed to be a judge and a jury. I'm going to provide you feedback on what it is I want you to get better at, as opposed to I'm going to determine whether I'm going to give you a 3 out of 5. Because you know as well as I do, a 3 out of 5 is a death sentence. Right? If you want to get if you're a medical student, you want to get into a good residency, if I evaluate you and I give you a 3, you're not going to get that residency. It's just not going to happen. Understand what motivates professionals. This is the book Drive by Daniel Pink, I think is who it is. Autonomy, Mastery, Purpose. This is what faculty are what, I think we need to understand our culture, what motivates the professionals. It's not money, it's not prestige, it's these things. And if we focus on those things, it can necessarily make us better. It's going to take ongoing study and revision, lots of pilots that are starting to occur, we need to learn from them. We can't be constrained by current rules, structures, or practices. And I encourage you to use the challenge as a platform for change, because change is an opportunity to redefine the profession. So finally, coming back to this, right? I encourage you, what does it think about? For you guys, I hope you view it as an opportunity, okay? Because this is an opportunity for us to really redefine our profession. Winston Churchill said, a pessimist sees the difficulty in every opportunity, an optimist sees the opportunity in every difficulty. And I think that's really, we as a system of medical educators, that's where we're really at. Questions? There's a couple of minutes left. Yes, sir.
Can you talk a little bit about challenge number 3 and the timing issue? You talked much more about will we actually graduate people 6 months early, and what will they do then? What about the flip side of the people who will take longer? And in particular, I'm curious because you mentioned, I think it's Toronto and their orthopedics. So in the surgical fields, at least that you hear the chairs, the program directors lamenting that because of work duty hours and everything else that's going on in healthcare, the trainees don't get enough cases. And I think you even mentioned in the beginning that it's not until their fellowship where they finally get OR time that's adequate to allow them to leave and practice. Does that mean we're going to have 6, 7, 8 year training programs because we wait for them to be competent enough?
Yep. So several different things. One is in Toronto, what they'll actually, when they went to this competency-based system, they actually found that the trainees actually stayed longer and they wanted to stay longer because that's where they perfected their skill, right? They actually found that opportunity. So they actually, not 6 months longer, not 6 years longer, but they stayed a little bit longer. And so that there's a real concern about that. But if In the context, it wasn't so that they could get a couple more cases. It was so that they could fine-tune their skills, having guidance, right? Think of that extended learning relationship that I talked about. I think that's really one way that we can move forward, right? Is how can in a surgical field, how can we actually extend that learning relationship to where we blur the lines, to where you leave my program, but you're not necessarily going to leave my supervision. Think about that. So there's an opportunity there, but that changes structure and changes the process for how it's done. In the financing of it too. Yeah, that's to say one of the barriers we have to really confront. I'm going to submit a paper pretty soon that's really based upon this and really just calls out how we fund medical education has to change, right? This isn't a GME funding talk. I have my own opinions about it, but we have to change our GME funding. And I think just trying to sustain how we've always done it is a barrier to competency-based medical education. Right? Our funding systems have to change. One of the other opportunities about residents leaving earlier, if we ever reach the point where, and I'll use internal medicine, that's what I do, where I have a resident and they're 2.5 years in and they have 6 more months of training left, and that's where our funding mechanisms allow us to do that. And if we ever reach the point where my faculty can't train that resident anything more and can't help them, push them to be a better physician anymore, if we ever reach that point, that's a wonderful problem to have, right? There's always the chance for us to be able to teach and to push and to help you be a better physician. What do we do with that remediation piece? Part of our, I think, the duty hours part, because I want to specifically address that, the duty hours piece, because as in surgical specialties, that is very real, absolutely very real. It goes back to the structures and the processes, right? Why are we set up the way that we're set up? Duty hours isn't duty hours to me isn't a duty hours question. Duty hours is a proxy for a supervision problem. It's really a supervision problem. It's not a duty hours problem. I think we've learned a lot about pushing forward from lack of sleep for 36 hours is really not a safe thing to do. I think we always knew that. I just don't think we ever admitted it. How can we actually structure a residency program that allows that autonomy, that allows the surgical intern or the second year or the third year to actually have the adequate OR time to begin to develop the skills? I don't live in a surgical world, I don't pretend to have that answer, but trying to just think of it in our current training environment, our current training structures, isn't going to get us to where we need to be. Yes, ma'am.
So if you guys come out with these charges and we've developed a tool to look at levels of entrustment for handoffs in the outpatient, and we're going to directly observe our residents, our third-year residents, and then we find that they're not all 5s.
Yep.
And all their things, and we were just talking about this morning, then I guess we're really just using that right now as formative feedback for them, and it's not going, we're still using other ways, the old ways. But is that still something we want to be doing? Because we want to start to look at it that way and say, well, okay, they're not all 5s in every single thing right now, but that's okay because 3 years have passed. Like, how do,
So
we obviously can't keep them anymore.
Referring specifically to the milestones?
Yeah, if you're using levels of entrustment, really. If you have an entrustment professional activity and you're looking at levels of entrustment and you have all these different things that are in the milestones, and now it's a third-year resident, and you're looking at them and, okay, you're like, well, they're not really able to do all of these things unsupervised right now.
So I'll try to reframe it a little bit, is how do we, if every resident hasn't necessarily demonstrated everything that we think they should be able to demonstrate by time certain, in our future state, and in a competency-based state, I think that's okay. Ultimately, it's still up to the program director. The program director still has ultimate authority to say, when I look collectively at the whole picture, this person's ready to enter into unsupervised practice. I still think there's it's still up to the program director to be able to do that. I would submit that everyone in this room probably is lacking or deficient in something.
So as long as you know you are.
Yep.
That's the way I always think about it. My residents
as long as you recognize it.
But they know that they're not. They have to look things up, and we're all looking things up. And we're all not always perfect in every way.
So in our future state, when you talk about that extended learning relationship, take the resident who's deficient in X or Y or Z, whatever the case may be. You're ready for unsupervised practice. Go practice 200 miles in Grand Island, Nebraska out there. But I want to work with you because I'm still responsible for your outcomes out there, at least for some defined time period, whatever the case may be. And I'm going to help you further that skill, but I can't train you in this environment to get better at that skill. I need to send you out there, and we're going to go out there, but I'm still responsible to train you even though you're 200 miles away. Now, that doesn't mean I have to sign your notes and bill for you. That's our old system that thinks about it. What can we do to have that extended relationship? And it also implies, what that does is that it specifically says, and as it specifically addresses the silos, once you graduate my program and you're out there, you're done. Never to be seen again. We have to move beyond that, because there's things that all of us are going to continue to work on. Education is a continuum that'll exist forever. Right now, we still require you to place a check on place an X and say you can sit for your boards. That's what we as program directors do. Let's get away from that. Let's change our structure. Let's change our process about how competence is assessed. Break down the silos between graduate and continuing education.
All right, I want to thank Dr. Caverzagie.